Your muscle mass is declining right now, not from disuse after an injury, not from a diagnosed muscle-wasting disease, but from a physiological process that began in your 30s and has been progressing steadily for years, regardless of whether you noticed weakness, balance problems, or changes in how your clothes fit. That decline is happening in the type 2 muscle fibers throughout your body, the fast twitch fibers responsible for power, strength, and the quick reactions that prevent falls. It is happening in your legs, where muscle loss affects your ability to climb stairs, rise from chairs, and maintain walking speed. It is happening in your core and upper body, where declining muscle mass compromises posture, balance, and the capacity to perform daily tasks that require lifting or carrying. And the rate of loss accelerates with each passing decade, creating a trajectory that determines whether you maintain physical independence into your 70s and 80s or require assistance with basic activities of daily living, decades earlier than necessary. Sarcopenia, the age-related loss of muscle mass and function, is one of the most under-recognized threats to healthy aging in the developed world. It does not announce itself with dramatic symptoms until function has already declined significantly, usually revealing itself gradually through subtle changes like needing to push off with your hands to stand from a low chair, walking more slowly than you used to, feeling unsteady on uneven surfaces, or noticing that carrying groceries or lifting objects overhead has become more difficult. The problem is that for decades we have been told that muscle loss is an inevitable part of getting older. You lose a bit of strength each year, you slow down, and eventually you accept reduced physical capacity as normal aging. Except that the rate and severity of muscle loss are not predetermined by genetics or chronological age. What we now understand from longitudinal studies and metabolic research is that sarcopenia is driven by modifiable factors, including physical inactivity, inadequate protein intake, insulin resistance, chronic inflammation, and hormonal changes, and that the muscle loss begins far earlier than most people realize, typically starting between ages 30 and 40 and accelerating after age 50. Most people have been losing muscle mass for 20 to 30 years without recognizing the progressive functional decline occurring or understanding that the trajectory could be altered through specific interventions. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in emergency departments, I have seen what happens when progressive muscle loss that could have been prevented leads to falls resulting in hip fractures, loss of independence requiring nursing home placement, and the cascade of complications that occur when elderly patients become immobilized from weakness. And my goal now is to help people understand when muscle loss actually begins, what the data reveals about the rate and consequences of sarcopenia, and what interventions have been proven to slow, stop, or reverse muscle loss based on the exercise physiology and nutritional science we understand today. For the next several minutes, I want to walk you through the actual timeline and magnitude of age-related muscle loss, explain the mechanisms driving sarcopenia, and provide you with evidence-based strategies to preserve muscle mass and function throughout your later decades. Okay, so if you are watching this video, you are probably concerned about maintaining your strength and physical independence as you age. And I just want to take a moment here to make you a promise. I promise to keep creating the most helpful, evidence-based videos I possibly can, grounded in clinical research and the latest science on aging and muscle physiology to help you live longer with preserved physical function. And all I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely useful about preserving muscle mass, then feel free to unsubscribe. No hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from over a decade in medicine and hundreds of hours reading research on sarcopenia and healthy aging. So please help me out, hit the subscribe button to help this channel reach more people like you, and let us continue with the video. When muscle loss actually begins, the data on age-related muscle loss comes from longitudinal studies that have tracked individuals over decades, measuring muscle mass through imaging techniques like DEXA scans and MRI, and assessing muscle function through strength testing and physical performance measures. What these studies consistently show is that muscle mass peaks in the late 20s to early 30s, and then begins a slow decline that accelerates dramatically after age 50. Research published in the Journal of Applied Physiology has documented that muscle mass decreases by approximately 3 to 8% per decade after age 30 in inactive individuals. This means that a sedentary person who had 60 kilograms of muscle mass at age 30 would have approximately 58 kilograms at 40, 56 at 50, and the rate of loss would accelerate to approximately 8 to 15% per decade after age 60. The loss is not uniform across all muscle groups or fiber types. Type 2 muscle fibers, the fast twitch fibers responsible for explosive strength and power, are preferentially lost. Studies using muscle biopsies have shown that type 2 fiber cross-sectional area decreases more rapidly than type 1 fibers, and that the number of type 2 motor units declines with age as motor neurons innervating these fibers die and are not replaced. This selective type 2 fiber loss explains why older adults often maintain endurance capacity reasonably well, but lose the ability to generate force quickly, react rapidly to prevent falls, or perform activities requiring strength and power. Research in Age and Aging has documented that grip strength, a proxy measure for overall muscle strength, declines by approximately 1 to 2% per year after age 50. And that walking speed, a powerful predictor of mortality and disability, decreases measurably starting in the 6th decade. The functional consequences of muscle loss become apparent when muscle mass and strength fall below critical thresholds. For men, appendicular lean mass, which is the muscle mass in the arms and legs, below 7.0 kilograms per meter squared of height, is associated with significantly increased risk of disability and mortality. For women, the threshold is 5.5 kilograms per meter squared. Once muscle mass falls below these thresholds, risk of falls, fractures, loss of independence, and all-cause mortality increases dramatically. Studies in the Journal of the American Medical Association have shown that low muscle mass is a stronger predictor of mortality as traditional risk factors like hypertension, diabetes, and smoking. Yet muscle mass is almost never measured in routine clinical care. What actually drives muscle loss, age-related muscle loss, is not simply the inevitable result of getting older. It is the consequence of multiple interacting biological processes, most of which are modifiable. The first driver is reduced physical activity, and particularly the loss of high-intensity muscle loading. Muscle tissue operates on a use-it-or-lose-it principle. When muscles are regularly loaded with resistance training that challenges them near their maximum capacity, they receive signals to maintain or increase size and strength. When muscles are not challenged, protein synthesis decreases, protein breakdown increases, and muscle mass declines. Most people become progressively less active with age, and critically, they stop performing activities that load muscles heavily. Walking is valuable for cardiovascular health, but provides minimal stimulus for muscle maintenance because the load is too low. Without regular resistance training or heavy physical labor, muscle mass declines progressively regardless of how much walking or light activity is performed. The second driver is anabolic resistance, which is the reduced muscle protein synthesis response to dietary protein and resistance exercise that develops with aging. In young adults, consuming 20 to 30 grams of high-quality protein stimulates a robust increase in muscle protein synthesis that lasts several hours. In older adults, the same protein dose produces a smaller and shorter duration response. Similarly, a resistance training session that would stimulate significant muscle growth in a young person produces less adaptation in an older adult. This anabolic resistance means that older adults require higher protein intake per meal, approximately 35 to 40 grams of high-quality protein, and more aggressive resistance training stimulus to achieve the same muscle protein synthesis response as younger individuals. Research in the American Journal of Clinical Nutrition has documented that older adults consuming protein at the recommended dietary allowance of 0.8 grams per kilogram of body weight per day lose muscle mass over time, while those consuming 1.2 to 1.6 grams per kilogram maintain or gain muscle when combined with resistance training. The third driver is chronic low-grade inflammation, often called inflammaging. Inflammatory cytokines, including interleukin-6 and tumor necrosis factor alpha. increase with aging and are elevated further by visceral adiposity, insulin resistance, and sedentary behavior. These inflammatory signals promote muscle protein breakdown and inhibit muscle protein synthesis, creating a catabolic environment that accelerates muscle loss. Additionally, inflammation impairs satellite cell function. Satellite cells are muscle stem cells that normally repair damaged muscle fibers and contribute to muscle growth. When satellite cell function is impaired by chronic inflammation, muscle regeneration after damage is less efficient, and muscle mass declines. Studies in aging cell have shown that inflammatory markers correlate strongly with rate of muscle loss, and that interventions reducing systemic inflammation slow sarcopenia progression. The fourth driver is hormonal changes, particularly declining testosterone in men and estrogen in women. Testosterone is anabolic for muscle tissue, promoting protein synthesis and inhibiting protein breakdown. Testosterone levels decline by approximately 1 to 2% per year after age 30 in men. This gradual decline contributes to progressive muscle loss, and men with low testosterone have significantly lower muscle mass and strength compared to those with normal levels. In women, the sharp decline in estrogen after menopause is associated with accelerated muscle loss and increased fat accumulation. Estrogen has protective effects on muscle through multiple mechanisms, including reducing inflammation and supporting satellite cell function. Research in the Journal of Clinical Endocrinology and Metabolism has documented that hormone replacement therapy in postmenopausal women can slow muscle loss, though the decision to use hormone therapy must consider individual risks and benefits beyond muscle preservation alone. And here is what you need to understand. The muscle loss trajectory is not fixed. You are not destined to lose 8% of your muscle mass per decade, simply because you are aging. The rate of loss is determined primarily by physical activity patterns, protein intake, inflammatory status, and metabolic health, not by chronological age. The data showing 3 to 8% loss per decade comes from observational studies of typical aging, which includes progressive physical inactivity and inadequate protein intake. Intervention studies where older adults engage in regular resistance training and consume adequate protein have demonstrated muscle mass maintenance or even significant gains well into the 7th and 8th decades of life. This is not your fault if you have been losing muscle mass. You were never told that muscle loss begins in your 30s, that protein requirements increase with age, or that resistance training is essential for muscle preservation. But now that you understand the mechanisms, you have the opportunity to alter the trajectory while you still have sufficient muscle mass and functional capacity to respond to intervention. What actually preserves and builds muscle? The most powerful intervention for preventing and reversing sarcopenia is progressive resistance training. This means exercises that load muscles with sufficient weight or resistance that you can perform only 6 to 12 repetitions before muscular failure. Walking, yoga, and light calisthenics are beneficial for other aspects of health, but do not provide sufficient stimulus for muscle maintenance in older adults. You need exercises like squats, deadlifts, leg presses, chest presses, rows, and overhead presses, performed with weights heavy enough to challenge the muscles significantly. Research published in Medicine and Science in Sports and Exercise has demonstrated that older adults engaging in resistance training 2 to 3 times per week gain muscle mass, increase strength, and improve physical function, even when starting in their 70s or 80s. The gains are substantial, often 10 to 30% increases in strength within 12 weeks, with corresponding improvements in walking speed, balance, and ability to perform activities of daily living. The key principles are progressive overload, meaning gradually increasing the weight or resistance as strength improves, and training frequency of at least twice per week for each major muscle group. Many older adults are told to use light weights and high repetitions for safety. This approach is ineffective for muscle building. Heavier loads are necessary to stimulate muscle protein synthesis and motor unit recruitment. Safety comes from proper form, appropriate progression, and supervision when needed, not from using weights too light to challenge the muscles. Studies in the Journal of the American Geriatric Society have shown that supervised resistance training programs in older adults have very low injury rates and produce far greater functional benefits than unsupervised or light resistance programs. The second essential intervention is adequate protein intake distributed appropriately throughout the day. As mentioned, older adults exhibit anabolic resistance requiring higher protein doses to stimulate muscle protein synthesis. The optimal pattern appears to be consuming 30 to 40 grams of high-quality protein at each main meal, 3 times per day, for a total daily intake of 1.2 to 1.6 grams per kilogram of body weight. High-quality protein means complete proteins containing all essential amino acids, particularly leucine, which is the primary trigger for muscle protein synthesis. Animal sources, including meat, fish, poultry, eggs, and dairy, are the most concentrated sources of high-quality protein. Plant proteins can meet requirements, but typically require larger servings to provide equivalent leucine content. Research in the Journal of Nutrition has demonstrated that older adults consuming protein at these levels in combination with resistance training gain muscle mass, while those consuming lower amounts maintain or lose muscle even when training. The timing of protein intake relative to resistance training also matters. Consuming protein within 2 hours after training maximizes the muscle protein synthesis response. For many older adults, achieving 1.2 to 1.6 grams per kilogram requires intentional planning because appetite often decreases with age, and habitual protein intake tends to be concentrated at the evening meal rather than distributed throughout the day. The third intervention is maintaining healthy body composition with minimal visceral adiposity and managing metabolic health to reduce inflammation and insulin resistance. Visceral fat produces inflammatory cytokines that accelerate muscle loss. Insulin resistance impairs muscle protein synthesis and reduces the anabolic response to feeding and exercise. Weight loss in overweight or obese older adults, when combined with resistance training and adequate protein to prevent muscle loss during the deficit, improves body composition by reducing fat while preserving or even increasing muscle mass. Studies in obesity have shown that this approach improves physical function more than weight loss alone or exercise alone, and reduces inflammatory markers that contribute to sarcopenia. The fourth intervention is ensuring adequate vitamin D status. Vitamin D receptors are present in muscle tissue, and vitamin D deficiency is associated with muscle weakness, increased fall risk, and accelerated muscle loss. Supplementation to achieve blood levels of 40 to 60 nanograms per milliliter has been shown in multiple studies to improve muscle strength and reduce fall risk in older adults, particularly those who are deficient. The effect appears to be greatest in individuals with low baseline vitamin D levels, suggesting that optimization is important, but supraphysiological doses above adequacy provide no additional benefit. Now, I need to add an important medical caveat. If you have not engaged in resistance training previously, starting a program in your 50s, 60s, or beyond should ideally be done with supervision from a qualified trainer or physical therapist who understands appropriate progression for older adults. If you have cardiovascular disease, joint problems, or other medical conditions, consult with your physician before beginning an exercise program. Some individuals may have contraindications to heavy resistance training that require modifications. What I am describing are general principles that apply to most older adults, but individual medical history must be considered when designing a specific training program. What I see in emergency medicine, in emergency departments, we see the consequences of progressive untreated sarcopenia. Elderly patients presenting with hip fractures from falls that occurred because muscle weakness and poor balance made them unable to catch themselves. People who have become functionally dependent because they can no longer rise from a chair, climb stairs, or perform basic self-care activities without assistance. Individuals experiencing repeated falls leading to traumatic brain injuries, fractures, and the fear of falling that further reduces activity and accelerates decline. What becomes evident is that these acute presentations represent the endpoint of years or decades of progressive muscle loss that was occurring silently while the person attributed increased weakness and declining function to normal aging that could not be prevented. The patients who maintain physical independence into their 70s, 80s, and beyond are overwhelmingly those who engaged in regular resistance training, consumed adequate protein, and maintained healthy body composition throughout middle age and beyond. These are not people with exceptional genetics. These are people who understood that muscle mass must be actively defended against age-related loss through specific interventions, not people who happen to age better. The data is clear. Resistance training and adequate protein can maintain or increase muscle mass at any age. The critical factor is whether the intervention is implemented before muscle loss has progressed to the point where functional limitations prevent effective training. The bigger picture is that sarcopenia is not inevitable. The 3 to 8% per decade muscle loss that characterizes typical aging reflects typical behavior patterns of progressive physical inactivity and inadequate protein intake, not an unavoidable biological process. Older adults who engage in resistance training 2 to 3 times per week and consume 1.2 to 1.6 grams of protein per kilogram of body weight do not lose muscle mass at these rates. Many gain muscle even in their 70s and 80s. The difference between maintaining physical independence and requiring assistance with daily activities in later life is determined largely by muscle mass and strength, which in turn are determined by resistance training and protein intake sustained over years and decades. So here is what I want you to take away from this. Muscle loss begins in your 30s, not your 60s or 70s. By the time you notice functional limitations from weakness, you have typically already lost 20 to 30% of peak muscle mass. The trajectory of loss accelerates with each passing decade, unless actively countered through resistance training and adequate protein intake. You cannot prevent sarcopenia through walking, yoga, or staying generally active. These activities are valuable for overall health, but do not provide sufficient mechanical stimulus for muscle maintenance. You need progressive resistance training with loads heavy enough to challenge muscles significantly, performed at least twice per week for all major muscle groups. You need 30 to 40 grams of high-quality protein at each of 3 daily meals, totaling 1.2 to 1.6 grams per kilogram of body weight. These interventions are not optional lifestyle preferences for healthy aging. They are biological necessities for muscle preservation that determine whether you maintain the strength required for independent living throughout your later decades. The return on this investment is measured in years or decades of preserved physical capacity, independence, and quality of life that would otherwise be lost to progressive weakness and disability. And finally, please subscribe to the channel if you found this video useful. It helps me reach more people trying to preserve their physical function and prevent the muscle loss that leads to disability. Thank you for watching.